So the next alarm goes off, and now it's a high peak, and you check the plateau, and the plateau's 25. So why would we have a high peak and a normal plateau? So what causes increased resistance? So bronchospasm, so that was mentioned, kind of this status, mucus secretions, a blocked ET tube, mainstem intubation, or bucking the vent, which means they're awake and asynchronous with the vent. Okay, so for bronchospasms, we're going to fix that with increasing the expiratory time, which Gary mentioned, and NEBs to improve the resistance. Mucus secretions, what are we going to do? Suction. Kinked ET tube, what are we going to do? Replace it, right? Mainstem intubation, we're going to back it out. And then bucking the vent, what are we going to do? Sedate. Right, and to Deb's point, that we want to make sure they're adequately sedated before we paralyze. We don't want a paralyzed patient that is not adequately sedated. All right, so now a low pressure alarm. So now the alarm is going off and it's telling you there's a low pressure. What could be causing a low pressure alarm? So the vent's disconnected, good. What else?
Balloon's down.
Good. Basically a disconnect or a broken balloon, a leak in the circuit. They accidentally extubated themselves. Bronchopleural fistula, which is rare but ominous cause. So vent disconnect, we reconnect it. How do you know if there's a leak in the circuit? What's a quick way of knowing if there's a problem with the ET tube or a problem with the circuit? What's that? Yeah, bag the patient, so that would be one way, but there's a really fast way. If you disconnect the circuit, let's say this is the part that goes in the ET tube, and you cover it with your hand. The ventilator, if there's no leak, it'll start making a barking noise. It'll make like this kind of like high-pitched barking noise. And that's just by doing that, if it makes that noise, you know there's no problem from here back to the ventilator. If it doesn't bark, somewhere in your circuit there's a leak or a disconnect. So that's a quick way of knowing if the ventilator is, and your RTs should know that trick. So the next thing was a cuff leak, and how are we going to fix that? We're going to replace it, but one they didn't talk about is using a manometer. And what's funny, at my hospital, the RTs, when they work in the ICU, they all carry manometers and they check the cuff pressure, but when they're assigned to the ED, none of them carry their manometer, which was kind of a puzzling thing to me. So if they're extubated, check your end tidal CO2, that's going to be your cue, and reintubate. We had to do a crash C-section, and my ED about 2 months ago, the near-term pregnancy, mom had pneumonia, went into respiratory failure, was successfully intubated. OB nurses came in and lift the patient up to get her on her left side and put the wedge in. We think that at that point the ET tube got dislodged. Everyone was in that post-intubation euphoria. Oh, thank God, she's intubated, everything's okay. So everyone was just kind of charting and doing their stuff, and it wasn't until the SAT started dropping, she wasn't on an end tidal CO2 monitor, and it wasn't until the SAT started dropping they realized that she's extubated, and then she arrested, did a crash C-section. Both baby and mother ended up surviving, but that could have been avoided by better vigilance. Bronchopleural fistula, you check the chest tube, look at the atrium. There's going to be a big, somebody get the door. There's going to be a big air leak on that atrium where there's a bronchopleural fistula, and we're going to try to selectively intubate either right or left. And just to demonstrate one more time, if you take the tube and basically take the angle on the tip, it's going to go towards whatever side the tip is pointed to. So if I pass it this way, you have a very high chance you're going to get a left main. If I flip it 180, very high chance you're going to get a right main. And again, you can try using the bougie as well. Certainly if you have fiber optic, that's 100% reliable. And if you have anesthesia, they can do even dual lumen intubation where there's a lumen in each main stem, and you actually have 2 ventilators going. All right, so in summary, end tidal CO2 is the only way we can confirm the ET tube is in the trachea. If they're dead and not exchanging gas, we need to rely on a mechanical measure, either the TUMI syringe or the bulb syringe. And then for ventilators, our goal is 7.2, SATs of 88 or better, FiO2 less than 60, ideal body weight, volume control, 4 to 8 cc's per kilo, and then try to kind of retain the best you can what it means when there's high pressure alarms with high plateau, high pressure alarms with normal plateau, and low pressure alarms, because you're going to do something obviously very different depending on what you encounter.